Welcome again. This is Dr. Bruce Karlin for Health Matters from WCCA TV and Worcester District Medical Society. Again, my guest is Dr. John Abramson, professor at Harvard Medical School. Not
Lecturer.
professor, lecturer at Harvard Medical School, and longtime friend of mine, and author of Sickening, which is well worth reading, and when we continue, you'll understand why. So let's take off from where we left off the last time. Maybe we can summarize in a few words what we accomplished in our last discussion and then get to your next point.
Yeah, so we talked about the problem of evidence-based medicine, that doctors are compelled to practice evidence-based medicine, which is in line with the peer-reviewed studies that are published in the clinical trials and in the medical journals and the clinical practice guidelines and the other associations like Cochrane reviews. That's evidence-based medicine. And we talked about the evidence upon which evidence-based medicine relies is not peer-reviewed by the peer reviewers. They don't have access to the real data. And
it's not a legitimate peer review. It's a quasi-peer review.
It's not quasi. They don't have access to the data. And I think that a great aphorism is evidence without data is not evidence. It's hearsay evidence. It wouldn't be admitted in a court of law. And the doctors don't understand that they're relying on this hearsay evidence to treat their patients. So they ought not to trust that this so-called evidence-based medicine is reliable and actionable to best serve their patients.
So we closed the last time with a slide that showed that what we see in the journals is supported. It was like an iceberg, and under the iceberg, it was supported by these clinical
by the actual data.
By the actual data, and that is hidden to the reviewers.
Right, but when I served as an expert in litigation, I got to see that, and I hope we can talk about that experience a little bit. But first, I want to say, so there's a problems with the evidence. It's not based on data, and therefore the accuracy and completeness of the reports that we read in peer-reviewed medical journals that are the foundation of evidence-based medicine aren't reliable. So we can't trust the accuracy and completeness of those reports. But there's another problem that's equally damning, which is the knowledge that's produced that doctors rely on is the sum total of American medical research. And that research has been largely privatized, as we talked about in the last show, and setting the research agenda has been privatized. So now 96% of American medical research is about drugs and devices, and only 4% is about how to serve Americans better with health care and improve population health. So last week, as we talked about, Americans are living 6.3 years less than the citizens in the other wealthy countries. Well, you might think that our research would address that problem, that in excess 500,000 Americans are dying every year because our health is inferior to the comparable countries. You might think that's a problem worth addressing. But the issue is that the agenda is set by the market, and the market, the pharmaceutical industry, it's the pharmaceutical industry and the device industry. So 96% of the research is about devices and drugs, and the reason for that is that the companies that are doing the research, sponsoring the research, have an obligation to maximize the return on the financial return on investment, not the healthcare return on investment, to their investors. So they have to invest their research dollars in the things that are going to pay off the most.
So their research dollars do show improvements with these drugs, but what you're saying is nobody's checked to see whether a little improvement by drug A, B, or C is worth it compared to, say, access to care for a poor American.
That's exactly right. And on top of all this, the United States is again exceptional in a negative way in not having health technology assessment. So we don't have any formal way to assess new drugs and to inform doctors and policymakers and insurers about which of the new drugs are genuinely better than older drugs and which ones are worth their cost. So you could have a drug that was better but cost so much money that it was going to leave society sicker.
Because we're not paying for the access for the poor guy to just get an insulin shot at a cheap rate.
That's exactly right. And now the new drugs that come out, only 1 out of 4 of them is significantly better than previously available drugs. And when we think about this, in 2008, the median annual cost of a new drug was $2,100. So, it's a lot, but
hefty something.
Hefty. The median annual cost of a new drug in 2022 was $250,000. $250,000. So when the Inflation Reduction Act says these new drugs can only go up at the rate of inflation, you're starting at $250,000, a median of $250,000.
You don't have to treat a lot of people for that to make money for your company.
Yeah, right. And what you're doing is pulling money out of society. Angus Deaton is a Nobel Prize winning economist at Princeton. And he wrote in the New York Times Book Review, American healthcare does a poor job of delivering health, which is what we're talking about, but it is exquisitely designed as an inequality machine, which is bad for health, inequality, commanding an ever larger share of GDP and funneling resources to the top of the income distribution. So when we take off the gold plate, all the glitter about our innovation, and what we have is a mechanism for transferring wealth from working Americans to the wealthy investors. And we don't have grown-ups minding the shop to make sure that in order to make a fair buck, the biotech industry has to deliver value for the new drugs they're making.
So, lest we sound like radical hippies again, I think that...
Strike thee again, please.
Or still.
No, strike, that's worse.
I'm just thinking, I mean, these drugs, they're not bad drugs, they're just way too expensive and oversold for the value added.
That's not necessarily true. Some are good drugs.
Yeah.
Some save lives.
Yeah.
I've had medical care recently that saved my life. It wasn't a drug, it was a procedure, but there's some good stuff out there. It's available in other countries. What the procedure I had was actually developed in Latin America. But there are some good drugs out there. But when we look at like the Alzheimer's drugs that are being approved now, and we're told that there's a 27, Leqembi, we're told that there's a 27% reduction in the rate of progression of mild Alzheimer's disease. And that sounds like a good thing. You get 27% reductions, statistically significant, why not try it? Well, why not try it is that the 27% reduction was actually 0.45 points on an 18-point scale, and the minimum, which was statistically significant, but the minimum clinical significance is a difference of 1.6 points. So it's the statistically significant benefit is only 1/4 as much as what would be required to have a clinically significant benefit, and yet the drug was approved.
So let's get back. As Mark Twain said, there are lies, damn lies, and statistics. So this sounds like one of those statistics.
Correct.
So it comes to the point where you're saying this is a drug that might have some improvement, but when we started the study off, and if we could have gotten down to the clinical reports, the actual reports, you might say, geez, we're really talking about 2 patients that got mildly better, and we don't know whether it met clinical significance, but...
Well, it's worse than that.
Oh.
A week after the FDA approved it, and this is now like 2 weeks ago
Yep.
from this taping, a week after the FDA approved it, it came out that there was really no benefit for women. The average was 0.45 points, which is a quarter of the 1.6 points that's meaningful. And for women, who are 2/3 of the Americans with Alzheimer's disease, the improvement was only 0.2 points. So you're having serious adverse events. And I mean serious, like 1 out of, I think it's the number needed to harm, for every 30, I think it's 37 people who are treated with Leqembi instead of a placebo, there's a serious adverse event. That means death or serious enough to end up in the hospital. So there's not proof. There is statistical evidence of benefit, but it doesn't meet the clinical threshold for benefit, and to tip my hat to Mark Twain, and there's evidence of harm. And this is going to cost $26,500 per person per year for the drug, and a total of $90,000 per person for every person who's taking the drug, because you need to be scanned to make sure your brain's not swelling or bleeding because you're taking the drug.
Why don't we get into, I'm going to need one of those procedures.
Yeah.
In any event, I was just thinking, there was one of my partners was talking about looking at a drug for cats that was a antibody, a monoclonal antibody. And it costs like $90 a month for cats. And he was saying, well, that's sort of interesting. Humira is in the same class, done the same way. And how much does Humira cost per month? And
Well, for a year, it's about $72,000.
Yeah. And he said, why isn't it $90 a month, the same technology?
Well, it only costs about $1,000 a year, if my recollection is correct.
Yeah.
It only costs about $1,000 a year to manufacture, and companies in India have been selling it for that. And part of the problem is that the patent has been extended so that companies in the United States aren't allowed to make generic Humira. They are in Europe, but not in the United States.
Well, there's your 90 a month, which is, that's your 1,000 a year.
Yeah.
In any event, we've got some extra time here, and I hope you've made the initial points about the loss of scientific integrity because of the way we're vetting our articles. I think you had one more point about that, and I didn't want to let you go until you talked about if you've covered the waterfront on that.
I think we have. I think that we doctors and we public need to understand that what's taken as evidence-based medicine the data have not been peer reviewed. The data has not been peer reviewed. And that what that information is about is 96% drugs and devices, when 80% of our health has to do with how we live our lives, what health habits we have, our health behaviors, our socioeconomic factors, and physical environment account for 80% of our lives. So people are listening, and I'm sure that I am a bummer and I'm depressing people. And I do want to get to a very important point, which is doctors don't know the right thing to do because they can't have the information, and the public doesn't. But we do know that 80% of our health is about how we live our lives. So like when we talk about statins, should I take a statin or not? We've learned to ask that question of our doctors, when what we're really asking is, what can I do to prevent heart disease, to decrease my risk of developing heart disease?
And it's been a very subtle change, because what we get is the expert panels say, well, you've got to check this ASCVD score, atherosclerotic coronary vascular disease score. And you come up with a number, you've got a 10% chance of dying in the next 10 years. And the big driving factor in that is your age.
Right.
And so when they apply this to people, you all of a sudden you sort of, oh, wow, the ASCVD score says I should use this statin, when it's really saying, hey, this is your heart disease risk. And the question shouldn't be, should I apply a statin? But as you're saying, it should be, what do I do to lower my heart disease risk?
Right.
Is walking going to be better than a statin?
We don't know. It's shocking that we don't know. And the reason we don't know is because no drug company has been willing to test a statin. They just test their statins against placebo and say there's a 20% risk in reduction of heart disease or something. They're not willing to add a third arm, a lifestyle arm, to compare walking, a healthy lifestyle, to statins, to placebo. And it's shocking to me that our FDA doesn't require that. The FDA has not only condoned, but actually accelerated this tendency to think about it's statins or no statins instead of how to prevent heart disease.
Well, it always struck me that you've got patients who smoke, and they say, I want my statin. And I'm saying, geez, here's smoking. Here's what stopping smoking will do for you. Here's what taking a statin will do for you.
You're right.
And there's no comparison. I almost want to say, why don't we compare just talking to people and seeing how well we do with smoking cessation techniques versus a statin.
Yeah, and you could also put in exercise and a healthy diet. It's very simple. This is not rocket science, but the companies aren't funding it.
So that's not the study that you see. You see the study says statin X is a little better than statin Y, and it has a little less side effects. You don't have muscle aches.
Right. So if I could take a couple of minutes and explain to people what we do know about statins, with the caveat that it all comes from the drug companies and they refuse to share their data. So this is a best case scenario. So for people who already have heart disease, those who take a statin, you have to treat 30 people who have heart disease with 5 years to prevent one heart attack or stroke, and the other 29 won't benefit. And you have to treat 80 people who have heart disease with a statin for 5 years to prevent one death, and 79 won't have death prevented. Now, most doctors, and when I was practicing, I would count myself among them, would say, hey, those aren't great odds, but if you're not having side effects, you might as well take the drug and eliminate the chance of being the 30th person or the 80th person. So it's worth a try. For those people who don't have heart disease, whose risk is less than 20% over the next 10 years, you have to treat between 100 and 140 people with a statin in order to prevent one non-fatal heart attack or stroke. And there is not significant evidence that it prevents a death. So instead of having guidelines that say you should or shouldn't take a statin, I think that doctors should tell their patients, and patients should seek out the information, and I hope everybody's listening, that it's not a yes-no question. If you want 1 out of 30, if you have heart disease and you want a 1 out of 30 chance of reducing your risk of another heart attack or stroke, then you should take a statin. And if you don't have heart disease and you want between a 1 out of 100 and 1 out of 140 chance of preventing a non-fatal heart attack or stroke, then you should take a statin. But that's your decision. That depends on your values and what you want to do. We don't know, as you were pointing out, Bruce, how those benefits compare to the benefits of exercising, not smoking, eating a healthy diet. But it looks like the benefit of adopting a healthy lifestyle is more potent, though it's not mutually exclusive. And many people, if they really want to do everything they can to prevent heart attack and disease, would take a statin if they qualify for it and understand the odds, and put their full attention in adopting a healthy lifestyle.
And certainly stopping smoking, which I'm sure takes less than 1 in 30 to improve your chances.
Big time.
Yeah.
Big time. Big time.
Interestingly, our Dr. Fulmer, who got our recent Lifetime Achievement Award, was teaching us to do smoking cessation back in 1970. '76,
nice.
and that was the push in the community medicine department to do those sorts of things.
And that's what we doctors should be doing. And that's been pushed out by the need for the funders of the research to maximize their financial return to their investors. We've got to understand that this is at the core of the problem. Now, it drives innovation for sure, but it's driving American health and healthcare in the wrong direction.
So we're spending it, and it's exciting innovation. I'm sure when you're doing these studies, they're fun.
Yeah.
I mean, as a researcher, hey, that's great stuff. But don't kid yourself. You're not making that much of a difference. You're making a difference, but it's certainly way out of proportion to the amount of money that is being injected into that endeavor.
Correct. And you need to understand that you're pulling that attention away from the public health measures that clearly would bring us back in line with the other wealthy countries.
So I hope that we can spend a minute or two about some of your exciting life history, because you've been you've been the witness for the prosecution of some impressive litigation. Can you share a little of that with us?
I can. When my first book came out, Vioxx was pulled from the market a week later, and I was all over the TV. And lawyers saw me on TV and saw that I could speak English and seemed to understand science, and started to ask me to be an expert in civil litigation, not criminal litigation, but civil litigation, where people who were injured by drugs and insurers and unions who paid for drugs that were overhyped would get some financial compensation. In that position, I would sign a confidentiality agreement, so I couldn't discuss what I learned, but I would get access literally to the computer hard drives of the key players, the scientists, the executives, and I could figure out what actually happened. That happened, Vioxx was everybody knows that name. A cousin of Vioxx was made by Merck. A cousin of Vioxx was Bextra, which was made by Pfizer.
So these were anti-inflammatory drugs that were supposed to, at the time we didn't know about the new pharmaceuticals that treat rheumatoid arthritis the way they do. It just quieted the inflammation down, presumably.
Right, but no better than over-the-counter drugs.
No better than aspirin.
Yeah, they were supposed to be gentler on the stomach and therefore safer drugs. They weren't. They caused cardiovascular problems. So I was in the civil litigation in Bextra, and I got to figure out how the numbers were rearranged to make the drug look safer. I can't tell you the details. I signed a confidentiality agreement. But it was so egregious that I picked up the phone and blindly called the Department of Justice in Boston and said, I know something about this drug, but I can't tell you because I'm under a confidentiality agreement.
Are you going to get in trouble for telling us this?
I'm not, because the Department of Justice and FBI sent out a marshal to deliver a federal subpoena for me to appear at FBI headquarters with my computer and explain to them what I knew about what happened. Pfizer was apprised of this. They had 10 days to intervene. They didn't intervene, and the subpoena was in force, and I showed up on time. And I showed these folks what I knew, and they were really smart. They had done their homework. Some of them, I think, were leaning in the direction of trying to protect the drug companies, and I'd be pretty sure that some of them ended up as defense counsel later on when they got in their real jobs after they did their government, stint. Yeah, thank you. They really kicked the tires on my analysis. And that was it. They said, thank you very much, and I went home. And they don't talk, just like the subpoenas that are going on now with the former president, they don't talk about what they're doing. They just do it. 6 months later, I read in the newspaper that Pfizer had pled guilty to a felony and was fined the largest fine, criminal fine, in U.S. history for any matter. It was the biggest fine in U.S. history. It was $1.195 billion.
So, and that's just, uncovering one drug. And I've got to say, at the time, I used Bextra, I used Vioxx at the time, and they were certainly very good for what they did. I didn't realize the downside of them because that had been hidden.
It had been hidden, exactly right. The big article that was written, it was in the New England Journal, they hid the cardiovascular. They didn't report the cardiovascular events. They didn't even report adverse events or serious adverse events. 1 out of 40 people who took Vioxx instead of a regular anti-inflammatory drug had a serious adverse event. The drug wasn't safer, it was way more dangerous, and 1 out of 40 people ended up in the hospital or dead.
So I've just been thinking, one of the things that strikes me, and it's always been a problem, is that statins do lower your cholesterol. There's no doubt about it. But cholesterol is vital to muscle function. And my wife is a rheumatologist, and she sees a lot of patients that have muscle problems. And if you take a look at the articles, you don't see anything about, they say, well, that's not that big a problem, but I'm sure that it is.
Here's why they say that. This goes back to the previous conversation about evidence. An article in JAMA showed that out of 41 studies of statins, only 1 asked about muscle problems at each visit. So it's see no evil, hear no evil. They don't ask. I mean, how can we live in an advanced society with an FDA looking over us and not require drug companies to ask about muscle symptoms for drugs that practicing physicians know increase the risk of muscle pain? We don't know how much because they didn't ask.
I'll tell you what, you want to stay on for another third and a fourth program because we're right at the end of what we have to do. My guest has been Dr. John Abramson, and we've been talking about scientific integrity and its relationship to how we evaluate drugs.